Good morning, everyone, and welcome to Pediatric Grand Rounds. Dr. Permeshwar is away today, so I have the pleasure of introducing our speaker, Dr. Klier. Dr. Klier is one of our third-year pediatric residents. He is a South Florida native and completed his undergraduate education at the University of Florida before earning his medical degree at Virginia Commonwealth University in Richmond, Virginia. He has enjoyed living in Roanoke the past few years with his wife and 2 young children who were both born during residency and were the inspiration behind today's presentation. He is looking forward, and we are very much looking forward to having him next year as our fourth-year chief. So please join me in welcoming Dr. Klier.
All right, good morning, everybody. Thanks for joining in person. And to those joining online, welcome. I'm excited to be here with you this morning, and I spent the past 3 years learning so much from all of you. I'm hoping to give back a little bit and teach all of you hopefully something about a topic that is near and dear to my heart. So I've titled today's presentation, Double, Double, Toil, and Trouble. We're going to be talking about providing holistic care for families with multiples. So without further ado, the kind of inspiration behind the Double, Double, Toil, and Trouble, it's a reference to Shakespeare's Macbeth in the play that, the nurses are stirring up their cauldron. It's supposed to, the literary effect is that it's supposed to signify the impending chaos that's coming. I feel like in the same way multiples have a way of multiplying chaos during the prenatal period, the perinatal period, once they arrive in the world at their well visits, when there's, 2 or more little children running all around the room. But also they have a way of really multiplying all the great aspects of parenting and the joys as well. I have no financial disclosures. 2 quick disclaimers. I have generally avoided making any specific product recommendations for caring for twins and multiples. I have very strong feelings about different products, and if that's something that you want to chat with me about, I'm happy to do that outside the setting of this presentation. And then finally, again, the goal of this presentation is not to diminish any of the different parenting experiences. Certainly there's unique challenges that come with parenting singletons, parenting multiple young children, being a single parent. The goal is to create a space to talk about some of the shared and unique challenges that come with parenting multiples. Some objectives for today's presentation. We'll be talking about types of multiple pregnancies and related trends. We'll talk about focus in on 2 specific time periods, the prenatal period and the perinatal period, and the risks that are associated to these gestations. We'll focus on some outcomes, once our multiples are born and how these kind of compare to singletons outcomes. And then a good part of the focus of the presentation will be on kind of the psychosocial component of caring for these families and talking about some of the unique challenges they face so that we're able to better counsel them and ultimately provide more holistic care for these families and care for them well. Here again is the inspiration for the presentation. The letters after my name give a little bit of credibility, but this is the real credibility here for today's presentation. So this is me when my twins were born just about 2 years ago. They have really shaped my residency experience and taught me just about everything I know about parenting in a practical sense. This is me like an hour after they were born, already looking very overwhelmed. And I like to think I've learned a couple things about parenting since they arrived. We're going to start with just like some quick low stakes true or false questions just to get our minds working and kind of thinking ahead to where we'll be going during this presentation. And then we'll dig deeper into these topics as we go along. So first, true or false, the frequency of multifetal gestations is currently increasing year to year. What do we think? Increasing, decreasing, staying the same?
Increasing.
This is going to be false. So there was a period of rapid increase related to a couple different factors that we'll talk about, but we have kind of hit that peak and now we're steadily declining. And we'll go into the specific rates in a little bit. True or false, more than 50% of twins are born preterm. Could be true, yeah. So again, we'll go further into details a little bit, but about 60% of our twins are being born preterm, and then even greater, 97, 98% of our triplets and higher order multiples are born preterm before 37 weeks. And then true or false, chorionicity is the greatest risk factor for morbidity in multifetal gestation. So the number of placentas is the greatest risk factor for these pregnancies. This is true, yeah. So the number of placentas will greatly impact a lot of different outcomes, and we'll go into details in a little bit. Here's a roadmap. This is where we are. This is where we're going. We're going to talk about background and trends and things like that. Again, we'll zoom in on the prenatal period and the perinatal period and talk about unique risks associated with these. We'll get into some outcomes as well. And then we'll do a lot of talk about at the end about how to care for these families and these children well, and specifically like how to counsel well on specific things related to specific to these families. Throughout all of this, I'll try to explicitly, but also implicitly, kind of refer to the various psychosocial impacts that affect these families as well. So first, getting into some background and foundation. Here's some trends. They come from the U.S. vital statistics. 2023 is the most recent year where we have like fully published data. There's a set of quintuplets here. One of them's being blurred out. This is, I guess, a real set of quintuplets here. There was about, in 2003, 110,000 approximately twins born, so about like 55,000-ish twin pregnancies. And we see much fewer, obviously, triplet pregnancies, and then even fewer than that, the higher order multiples. About 30 per 1,000 live births is the estimated rate for twins, so about 3% of our patients. So a smallish number, but definitely not insignificant. And then that number for triplets and higher order multiples, a little bit hard to really even interpret, but again, generally relatively low, but something that we can certainly encounter. Getting a little bit more into the trends as discussed. So with respect to twins, we did see that rapid increase, nearly doubling from 1980 to about 2009. And then since then, I've had kind of a leveling off and very slight decline since that period. As far as triplets and higher order multiples go, again, around 1980 saw a rapid increase, about 400% until peaking in 1998. Since then, again, rates have decreased, fallen off by about 60% from that peak, and then year to year, about 6% from like the prior year compared to the most recent data. What's driving that? There's a couple different factors. I'll talk a little bit more about them in specifics on the next slide, but two of the main factors are going to be the trend towards older maternal age. As we'll see, there's association between older maternal age and risk for multiples, especially like dizygotic multiples in particular. And then also the use of assisted reproductive technology has driven a lot of this. The most recent data I could find was from 2017 in terms of outcomes for ART, and with that data, about 25% of these pregnancies resulted in twins and about 1% higher order multiples. Certainly that number has gone down with time, and largely what's driving that trend is the shift towards single embryo transfers and away from multiple embryo transfers, and that's a complex issue that probably deserves its own presentation. But there's competing interests where there's a lot of cost involved with embryo transfers, and we want them to be successful, and there's a lot of pressure on them being successful, and that kind of has to be balanced with the risks that are conferred with the higher order multiple pregnancies. And so we have seen a shift towards single embryo transfers with time. Here's some of the more specific information about risk associated, or like what causes increased risk for multifetal gestation. So as mentioned, older maternal age. So for our younger than 20-year-old mothers, about 16 per 1,000 live births. For older than 40 mothers, about 70 per 1,000 live births, like a 4 times increase for older mothers. As mentioned, the use of assisted reproductive technology is driving a lot of this, whether that's in vitro fertilization or the use of like serotonin, like selective estrogen receptor modulators. Again, driving like increased ovulation for fertility reasons and causing hyperovulation. And then we see in other ways things that can like increase the risk for like hyperovulation, that can increase the likelihood of dizygotic twins. So we see that moms who have previously had multiples or an increased likelihood to have additional multiples with further pregnancies, like 2 to 3 times higher risk. Again, likely due to a propensity to ovulate multiple eggs at one time. And then there's some genetic component to this as well. There's been a couple genes implicated. There was a Swedish study that looked at moms who were dizygotic twins themselves and found that they had an increased likelihood of having dizygotic twins when they became pregnant, with like a relative risk of about 1.3. Again, what's driving this likely related to kind of genetic propensity to hyperovulate. And so that's going to ultimately affect our like dizygotic twin rates. Again, monozygotic twins is going to be kind of its own independent thing that typically doesn't have a genetic association. We're going to talk about some important key terms here. So zygosity, just so we're all using the same terms here. Our dizygotic twins typically going to be referring to our fraternal twins, whereas our monozygotic twins are going to be more of our identical twins. So with our fraternal and dizygotic twins, we see 2 separate eggs fertilized by 2 separate sperm, resulting in 2 distinct zygotes. Whereas with our monozygotic twins, we have 1 egg fertilized by 1 sperm. That zygote splits at some point within a couple days of fertilization, and then based on that, we're going to see different types of monozygotic pregnancies, which are shown here. So we'll quickly talk about like chorionicity and amnionicity for monozygotes. Again, depending on when this cleavage happens, we get different pregnancies. So the general trend is that the earlier the cleavage happens, the lower risk the pregnancy, and the later the cleavage happens, the higher risk the pregnancy. So when we have very early cleavage in those first couple of days, that's where we get our di-di twins, so dichorionic and diamnionic, and that's going to be our lowest risk multiple pregnancy. And then we see as we get later division, we get our monochorionic diamnionic pregnancy, and later than that, our mono pregnancy. And then finally, very late cleavage and very rare would be like our conjoined twins. It is good to determine what the chorionicity is early in pregnancy, which is why prenatal care is super important. It's going to guide kind of what the monitoring and management will look like, and plans for delivery and things like that. Worth noting that, again, with our multiples, like higher order pregnancies, there can be any combinations of these, so we can see like dizygotic siblings as well as like monozygotic siblings and combinations of those for our higher order multiples. As alluded to earlier, chorionicity matters, and this is why. So for monochorionic pregnancies, they are at increased risk for a variety of complications, most notably like increased risk for prematurity and stillbirth, other issues with like growth restriction and growth discordance, and as we'll talk about twin-twin transfusion syndrome. They're at increased risk for like some congenital anomalies as well, which is why it's recommended that they get like fetal echoes done in the second trimester, because there is increased risk for congenital heart disease as well. We'll have a slide later on twin-twin transfusion syndrome, but not an insignificant percentage of our monochorionic pregnancies have some component of twin-twin transfusion syndrome, which will certainly require maybe some intervention or may lead to earlier delivery. And when this exists, these pregnancies become highly medicalized, even more than they already are, requiring like frequent ultrasound scanning, even beginning in like the second trimester. Why amnionicity matters, again, it confers increased perinatal mortality for our monoamniotic pregnancies. So these pregnancies also require like much closer monitoring, and then worth noting that these multiples can be delivered vaginally. However, as you can imagine, there will be increased risk to the second after the first delivers because of increased risk for cord complications after the first multiple delivers. So again, some lack of autonomy, I guess, in terms of like birth plans and things like that for these pregnant mothers. Conjoined twinning, I'm not going to go a whole lot into this. It's incredibly rare. Again, important to that when it's recognized early to identify what the shared anatomy is, and that's going to guide prognosis and things like that. I think it's been a little bit glorified. I can probably all remember certain TLC shows that show like wonderful stories of conjoined twins and things like that. But ultimately, there is generally a pretty low survival rate from when these conjoined twins are identified to a potential separation eventually, if that's even feasible. So now we'll zoom in a little bit on the prenatal period and talk about surveillance. Again, these pregnancies are highly medicalized by default. There's going to be serial ultrasounds, close monitoring for growth. For monochorionic pregnancies, there's going to be ultrasounds every 2 weeks beginning in the second trimester and every 4 weeks for dichorionic pregnancies. Again, even closer monitoring if there are any complications, if there is any concerns for growth restriction or growth discordance or twin-twin transfusion syndrome. And again, by default, these pregnancies are high risk, and so families will not only have their regular OBGYN appointments, they'll also be following with maternal fetal medicine and have additional appointments and monitoring on top of that. These mothers will be placed on aspirin prophylactically due to their increased risk for hypertensive complications, specifically preeclampsia. We talk a little bit about genetic testing here. Again, something that some families may choose to pursue, but it's worth noting that in multiple pregnancies, there is decreased sensitivity with this thing and some increased risk for false positives. So generally, we're going to think about for our monozygotic twins, these should be, they should share the same kind of DNA and same karyotype, but certainly there is the small risk for discordance between them. With our dizygotic twins, we could think about if we do get an abnormal screening, well, at least one of them is going to be abnormal, but is it both of them? Hard to say. So with like our cell-free DNA screening and NIPT screening, we can see, again, unequal contributions of fetal DNA to mom circulation, which again could result in potentially masking some like aneuploidy. So we get a negative result, but maybe really only picking up on like one of the fetus's DNA and kind of missing the other, which is why ultimately doing things like checking for things that are specific markers for like each individual multiple is important. So things like nuchal translucency and kind of our anatomy scan as a whole will be particularly helpful. Certainly you can do more definitive testing like amniocentesis and chorionic villus sampling, but that does confer a little bit of increased risk to the pregnancy for multiples. With that said, I would say generally a good idea, even if reportedly there's normal genetic testing, to at least in the back of your mind have a thought that potentially could something have been missed? Like maybe I should if there is concern for maybe something underlying in terms of chromosomal abnormality or something, just because there was normal sort of prenatal testing doesn't necessarily mean that that's the case for all of the multiples. Growth discordance, as you can see, these two siblings are very different in size. Typically, we're defining growth discordance as a discrepancy greater than 20% in terms of weight, and this is important because it confers some increased morbidity and mortality, and we'll peek at some data in just a second. Different reasons for this to happen, right? I mean, certainly there can be different genetic potentials between developing multiples. Certainly there can be like underlying chromosomal things, but often the cause will be kind of unequal sharing of nutrients from the placenta itself and supply and nourishment to these developing fetuses. There was a 2025 study done in a London hospital over a 3-year period that looked at over 800 twin pregnancies, and they used some like machine learning to develop kind of trends in growth discordance between multiples. And here's what they found, kind of 5 distinct trends. So that orange line represents our very discordant twins that are have a large difference in weight, generally remaining stable. And then that blue and purple line represent the ones that kind of have more of like a mild discordance. And some of those will go on to have an increasing amount of discordance, whereas some will go on to have decreasing discordance with time. And then that red and green represent the kind of minimal discordance. But again, there's a risk for them to become more discordant with time versus kind of being stable. And based on these trends, they looked at morbidity rates and mortality rates, as well as NICU admission rates. And again, generally what they found is that the more discordant the twins, that orange group was at highest risk for morbidity and mortality, as well as NICU admission rates. And then generally, as the multiples became less discordant, they typically had less complications with time. I mentioned briefly twin-twin transfusion syndrome. Generally speaking, this is going to be related to kind of unequal or some abnormal anastomosis in the placenta itself, resulting in like transfusion of blood from one of the developing twins to the other twin. And so what we see is this distinction between our donor twin and our recipient twin. The donor twin being much smaller, related with oligohydramnios. This one is going to be at risk for severe anemia and certainly at risk, increased risk for mortality. And then conversely, what we see with the recipient twin who's receiving the transfusion of blood is essentially an association with polyhydramnios. This is going to be the much larger twin at risk for things like cardiac overload, cardiac failure, and certainly increased mortality as well. As mentioned, like the data on that is, again, to some extent, it's not a particularly rare complication that can occur, and when it does, that will certainly require close monitoring. We'll talk certainly about risk related to the developing fetuses themselves, but certainly multiple pregnancies confer additional risk to the mothers as well. And we see that through all parts of the pregnancy. So early on, first trimester with increased risk for hyperemesis, and then throughout pregnancy, increased risk for developing gestational diabetes, increased risk for sort of perinatal complications with postpartum hemorrhage, requiring increased rates of C-section, then even after delivery of the infants, increased risk for postpartum depression, and we'll talk about that a little bit later. And then most importantly, certainly increased risk for hypertensive disorders as mentioned, which is really going to drive some of that increased risk for prematurity. And we see generally the trend is that the number of fetuses kind of directly affects the risk for hypertensive complications. And so we see lowest risk for singletons, but then higher risk for twins and even higher risk for triplets. And interestingly, with the use of assisted reproductive technology, we actually see that that is an independent risk factor in and of itself for preeclampsia with a relative risk of 2.1. Going into perinatal period, again, these deliveries are going to be high risk. Certainly at risk for preterm delivery related to hypertensive complications, but also a variety of other factors as well, depending on the number of fetuses, what the chorionicity looks like, and then certainly other risk factors if there's concerns for growth discordance or twin transfusion syndromes and things like that. Again, these deliveries increase rates of C-sections, and certainly they, because of the risk for complications, and depending on provider comfort, it may often be recommended that these women deliver in the operating room, even if planning for vaginal delivery because of risks that can occur. And as an aside, I was glad that that was the route that our OB had decided, because after our first twin delivered, the second one's heart rate dropped and we needed a stat C-section. And so it was great to save those precious minutes having delivered right in the OR to be able to convert kind of emergently. Again, all of this said, I kind of want to highlight how there is a lack of autonomy often with birth plans for these mothers, and that can certainly be an important consideration for them and kind of their experience throughout the pregnancy and the delivery process. And then again, we see kind of lack of autonomy just in terms of timing of delivery and optimal routes, because again, that's going to be determined by a couple different factors. Again, the number of fetuses, what the presentation looks like, which is true for any pregnancy. But again, a lot of it's going to depend on kind of the comfort level of who's delivering the multiples. And so some OBs may feel comfortable, delivering vaginally the first twin, even if the second is breech, and then kind of doing an extraction that way. Versus some might say no, I'm worried about the second twin flipping or something like that. A C-section would be recommended. And then, as mentioned earlier, for monoamniotic twins, certainly increased risk for cord complications at timing of delivery after the first delivers. And then we'll go into some more data in a little bit, but there is increased mortality for allowing these pregnancies to go beyond a certain gestation, which is why there will be recommendations for delivering at a certain time point, because allowing the pregnancies to persist confers additional risk that outweighs the benefit of allowing them to continue. And so typically di twins are going to be delivered by that 38-week mark, and then mono-di twins delivering by 37 or so weeks, and the mono twins delivering earliest typically by 34 weeks. Here's some nice data that just looks at differences between pregnancies with singletons and multiples. And so we can see, again, it makes sense, but birth weight is typically going to be lower depending on as there's more and more multiples. Generally, the gestational age that these infants are born at is going to be lower and lower as well, the more multiples there are. Again, as alluded to earlier, we see increased prematurity rates, about 60% for twins, and then as high as 97, 98% for triplets and higher order multiples. We see increased rates of cerebral palsy, again, increasing with number of multiples, and then certainly increased mortality as rates as well. Talking about NICU admissions, I found a study from 2019 that just looked at NICU admissions as a whole and what percentage of those are multiples. They found 14.5% or so. I spent some time in the NICU recently, just so I did my own sort of informal observational studies of how many of these kiddos are twins or higher order multiples on our unit right now, and found kind of similar data, 13 to 20% of our NICU when I had been there not too long ago were multiples. So again, not an insignificant number. And then certainly a unique aspect of caring for these families is the possibility for twin loss, whether that's prenatally, whether that's perinatally, and that's going to be an important thing to navigate with these families. Again, as far as prenatal mortality goes, there's risk for intrauterine demise, a not insignificant percentage, 5% in twins and 17% in triplets during the kind of later periods of pregnancy. And when there's complications and demise with one of the developing multiples, that confers a lot of increased risk to the other remaining multiples. So for the surviving twin, again, related to like a 15% mortality risk for the monochorionic pregnancies, less so for dichorionic. And in the same way, we see significant increased risk for like neurologic abnormalities for the surviving twin, 18% in monochorionic pregnancies and less for dichorionic pregnancies. But certainly you can understand that this creates could potentially create a lot of unique psychosocial stress for family and grief and things like that. I know I personally had like interacted with a family who had experienced twin loss kind of perinatally, and have seen them over the past couple years of residency in various outpatient subspecialty clinics. And I think they brought up the child that we're seeing is a twin, and that, and it really has impacted them. They bring it up at every single visit. It's clearly affected them greatly. Some details or specifics regarding perinatal mortality. So 5 times increased risk for stillbirth, 7 times increased risk for neonatal death. Again, this is the data that kind of shows why we don't want these pregnancies to progress too long. And so for dichorionic and monochorionic pregnancies, generally the trend that we're seeing here is once we're getting beyond 34, 35 weeks, the rates of stillbirth are increasing, and not insignificantly once we get beyond that 37 to 38 week mark. We'll talk a little bit about outcomes here. Again, as a whole, outcomes mostly driven by degree of prematurity. Certainly the use of assisted reproductive technology confers some additional risk for genetic abnormalities. The thought behind that is probably that there's underlying cause for infertility in the first place, and not so much that specifically related to the use of ART in and of itself. Interesting kind of thought that I was like, well, that uterus can get pretty crowded. Are we going to see issues with like crowding complications for our multiples? And so here's what the data shows from my kind of literature review. For developmental dysplasia of the hip, not really increased risk. Generally, again, that's going to be our sort of like firstborn female, certainly if breech or if mom has a history of developmental dysplasia, but the data doesn't really play out that our multiples are having more developmental dysplasia. Same for clubfoot, not really an increased risk. Again, that's going to typically more be a genetic thing. Interestingly, there is an increased risk for false positives. So identifying a clubfoot on ultrasound prenatally when there isn't really truly a clubfoot, it's likely related to crowding that's being picked up in utero that doesn't actually result in a true clubfoot once delivered. I did find data to suggest that maybe there is an increased risk for torticollis related to crowding for multiples. So something to be aware of. Neurodevelopmental outcomes, again, often going to be related to prematurity and low birth weight, but we can see certainly it's going to be important to make sure that these kiddos are well plugged in with a variety of supports, different therapies and developmental clinic and things like that. Interestingly, though, we do see for like age-matched twins compared to singletons, increased risk for cerebral palsy. So like a 2 times increased risk for high-grade IVH and periventricular leukomalacia for our less than 32 weeks twins compared to our less than 32 week singletons. There was a study from 2018 that looked at like language development. Over 400 twins were included in the study, and they were looking at late language emergence, which their cutoff for that was around the 2-year mark. And what they did is kind of looked at a communication index they had developed and kind of determined if the twins were less than 10th percentile on that index. And they found with an odds ratio of 7.6 that twins did tend to have more late language emergence. And we'll talk about maybe reasons for why that is in a second. And then some additional studies looked at singletons, twins, and then higher order multiples and compared rates of like death and neurodevelopmental impairment at a corrected age of 18 to 22 months. What they defined as neurodevelopmental impairment was things like blindness, severe deafness, moderate to severe cerebral palsy, and then like psychomotor and developmental delays. And they found that an odds ratio of 1.7 for very low birth weight multiples compared to very low birth weight singletons. So even for if they're small and premature, still some increased risk for neurodevelopmental impairment and certainly mortality. Growth differences. We'll talk about this a little bit, maybe not clinically significant, but maybe some interesting data to think about. So there was a study from 2025 that looked at height, weight, BMI outcomes for multiple, specifically twins. Again, there's a lot more data out there for twins compared to higher order multiples. And so what they found was generally twins were shorter by the age of 3 and then hadn't fully kind of caught up in terms of the total height potential by reaching adulthood. In the same way, twins tended to weigh less at their time point of 3 years and by reaching adulthood, and then generally also had lower BMIs. And then interestingly, again, this persisted even when correcting for gestational age at delivery. A 2025 study actually developed some growth charts that we'll peek at on the next slide. But they looked at growth and catch-up growth, and they compared that to not only like all singletons for twins, but also like age-matched singletons as well. And again, unsurprisingly, they found that twins tended to be born at lower birth weights. For males, they would have rapid weight gain early infancy and would actually catch up to age-matched singletons by around 6 months, and then catching up to all singletons by a year of age. However, for our female twins, we saw a little bit slower catch-up growth. So again, rapid growth early infancy, but taking about 15 months or so to catch up to their age-matched singletons. And then by the end point of the study, around 24 months, those female twins hadn't fully caught up to their singleton counterparts. And so the conclusion of that study was maybe we should consider, like, should we use kind of like twin-specific growth charts, especially like early in development, when we're thinking about how well these kiddos are growing and what their catch-up growth looks like. You can see the growth charts here. I wouldn't say there's a significant difference in them in terms of do we need a whole new growth chart for this? Maybe not, or maybe this just deserves some like additional investigation. But you see on the left is our male twins, on the right is our female twins. The solid line being the twins, and the dotted lines representing age matched and all singletons. Generally, again, on the left there, we see the males catching up at some point. We see kind of crossing of lines at the 6 and 12 month mark. And generally, kind of by that 2-year endpoint, we're kind of at the same point. Whereas for our female twins on the right, again, that kind of slower catch-up growth, crossing around that 15-month mark in terms of catching up to our age-matched singletons, but never fully quite meeting the growth or the size of singletons by the 2-year endpoint. Again, is this clinically significant? I don't know. Maybe just deserves some additional investigation. I touched on this a little bit earlier, but postpartum depression is going to be an important consideration when caring for these families. So certainly these families tend to rate higher levels of stress and sleep deprivation, especially during that newborn early period. And this can certainly be related to like increased risk for postpartum depression. So I found a 2009 study that looked at a good number of moms, over 8,000, that found that with an odds ratio of 1.43, mothers with multiples were at increased risk for postpartum depression, and we'll touch on reasons for that in a little bit. Getting into some like unique challenges parents face and how to counsel these families well. Something that may come up is concerns for bonding. So again, a little bit more straightforward when we're taking one baby home from the hospital. Parents are putting a lot of their attention on this one newborn, and we can kind of see some unique challenges when we're taking 2 or 3 or more newborns home, obviously, from the hospital, and trying to divide attention and care for all of them well. And then certainly, again, with the increased likelihood of NICU admission, there is certainly challenges that are related with that, and trying to bond with our infants as well. Breastfeeding, or feeding in general, it can be a struggle, but breastfeeding specifically, again, the AAP's recommendation is going to be that if we can provide breast milk and breastfeed these infants, that's going to be best for them and confer a lot of benefits. Certainly, there can be lots of challenges related to this. Postpartum challenges, increased postpartum depression rates. Certainly the NICU, again, can certainly cause stress for these families and certainly create barriers that can affect mom's milk supply. There's obviously technical challenges with trying to satisfy and nurse more than one infant at a time. And then certainly some moms may find that their milk supply doesn't seem sufficient for like fully satisfying the needs of 2 or more infants at the same time. I found some data, and it'll probably look different depending on what country you look at and like what year the data is coming from. But that study found that in terms of like rates of exclusive breastfeeding, about 4% of our multiples were being exclusively breastfed. as compared to like 44% of singletons in that study. So definitely less rates of exclusive breastfeeding, and that's, again, for a variety of reasons, but important to counsel these families well to make sure if it is a goal of theirs that we're connecting them well with lactation early, certainly praising and encouraging any amounts to provide any amount of breast milk for these families, and then certainly creating a space to say that, again, feeding our babies is ultimately the most important thing. And so, if they need to supplement with formula and things like that, that is totally reasonable and good for their babies. I think this presentation wouldn't be complete without at least talking about breastfeeding multiple babies at once. Again, obviously can be a challenge, certainly related to trying to technically navigate this process, and then, I don't know, one twin hitting the other twin, and causing the other one to unlatch and things like that. There's different positions that can make this more helpful, and lots of great products designed to help with supporting the weight of these infants while breastfeeding to kind of optimize things. But again, very, very challenging and cause a lot of frustration for mothers as they sort of figure out this process, especially moms who are new to multiples. Sleep is going to be an important thing to talk about as well with these families. So unequivocally, the AAP has the same recommendations for safe sleep for multiples and singletons. Certainly there will be increased risk for SIDS for these families because of low birth weight, because of prematurity. A term we don't use a lot is co-bedding. Co-bedding refers to sleeping multiples in the same crib, the same bassinet. Depending on what country you look at, there kind of are like some different recommendations for this, but the AAP's recommendation is not to co-bed our very small multiples. Certainly they should room share, but be on their own, like safe flat surface on their back, nothing in the crib that could potentially suffocate them or obstruct their breathing. I did find a study that kind of looked at co-bedding rates and found that at the 4-week time point, 65% of parents, it seems pretty high. And so I don't know what's true in practice or not, but they found like 65% of parents were co-bedding their multiples, so that's kind of that 4-week mark. So all that to say, it's important that we model like safe sleep while these kiddos are in the hospital, and then certainly encourage this and reinforce this at home, and encourage safe sleep while at home. Something that's going to be important, do you want me to try to exit that? Something that's going to be important to try to counsel families on is like sleep schedules and trying to synchronize these infants. So again, as you can imagine, with 2 fresh babies or more home from the hospital, they're going to have very unique needs. They're going to need to feed often. And so if we're feeding every 1, 2, 3 hours, if we have different sleeping and feeding schedules, it is going to be a constant cycle of waking up, feeding, going to sleep, waking up, feeding, going to sleep, and no rest for the tired parents. And so as best as we can, we should try to synchronize schedules, which I certainly understand is a challenge. But what that may look like is one infant wakes up to eat. Okay, we're all waking up to eat. Like we're going to eat together, and then we're going to go back to sleep. And trying to reinforce kind of same nap times and things like that as they get older can really like help reduce the burden on these families. Getting into from infancy to toddlerhood. Again, developmental delays thought to be more of like an issue previously than like kind of how the data plays out, aside from the issues related to like prematurity. But we do see like increased like mild speech delays. Why is that? There's a couple of different like considerations. One thought is, are there like interrupted speech patterns between parents and their multiples? So again, we're trying to give that one-on-one attention to like one of the infant or one of our developing toddlers, and then that attention is being pulled away to the other child, and so we're getting kind of fragmented interactions. Maybe that could be playing into it a little bit. We've all probably heard of this like secret twin language or telepathy. That's probably more of like a myth than anything, but we can see like reinforcement of immature speech patterns between more isolated like couplets and higher order multiples. So those are like the twins and triplets that are that don't have older siblings or aren't in daycare. We can see like kind of this private language that reinforces some of that immature speech. But again, kind of doesn't play out for less isolated multiples. You probably ask, poll a bunch of parents. They'll probably say that their child's tantrums are severe and worse than other kids, especially if they're in the thick of things. But generally, parents with multiples might rate tantrums as more severe. Reasons for that could be related to like competition for attention, right? So one child has needs and is expressing them, and the other child has needs and wants to express those more loudly and kind of get the attention of their parents, and certainly that can be issues for families with multiple young kiddos as well. Important to reinforce to parents, we don't want to be comparing these children to each other in terms of their development. So we want to compare these children to developmental norms, and it can be easy for parents to say, well, this one's doing this, and why is this one not doing that? But again, these are like siblings, right? Siblings can certainly develop at different rates, like they're not the same person. And so we want to reinforce, try not to compare them, but to rather compare them to what developmental norms look like. And then getting into childhood, adolescence, this is going to be an important time period for these kids, where they're really starting to develop their personal identity and independence. And we certainly see that an important part of that identity is being a multiple, and that's something that should be celebrated. And we see that as these kids get older, they tend to place higher value in that identity, but families should still be encouraged to really promote kind of their individuality, and we'll also, again, kind of celebrating the unique bonds that come with being a multiple. Always good to encourage any parents, whether it's multiples or kids with multiple, or parents with multiple young kids, to really try to have that one-on-one time with their kids, which is really important. And then generally, from a sense of trying to help them create this sense of identity, probably good to avoid always calling them the twins and the triplets and things like that, but call them by their names and try to help develop that sense of individuality for them. And then an interesting topic is, like, should these kids be in the same class as they enter school age? Should they be in different classrooms? There's no great data to say one way is better than the other. Generally, the recommendation is that parents should have the choice, and there's like law that exists in a lot of states that affords parents that choice. Parents might find logistically it's easier for their kids to be in the same class. And there is some data that suggests that maybe boys who are multiples do a little bit better emotionally when they're in the same classroom as their multiple. But again, no like one way is best for these families. It probably needs to be a conversation between families and what is best for them, but also kind of how their individual multiples do in the school setting, and if it's best to keep them together or separate. Some unique parenting challenges. Again, very complex dynamics to our interaction. So with the typical parent-child interaction, again, these are dyadic interactions. The parents interacting with the child. But then, when we get into twins and triplets, we're seeing not only that parent-child interaction, but that parent's interaction with each of the other children, and then the dynamics between each of the twins and each other, or the triplets and each other. And so that can definitely create some additional stress as we're trying to navigate some of this newness when these kiddos are younger. Certainly, parents are not immune to feelings of like feeling inadequate or guilty because of having to divide their attention between multiples, especially if one of these children is like higher needs medically or needs additional comfort. Not uncommon to see one of these multiples who's very calm and happy and kind of less demanding on parents, than one that is very fussy and needing a lot more individualized attention and always needs to be held, whereas the other one's kind of always just being placed down, and kind of those feelings of I'm not caring for them equally because they have different needs. These parents can definitely experience some isolation and fatigue, especially during the newborn period, and so as best as we can encourage them and support them will be important. There are some helpful support groups and things like that, different online communities that I have found helpful, Reddit communities, parents of multiples, parents can share parenting tips and things like that. There's certainly good Facebook groups, and then on more local levels, groups for multiples as well. Certainly if parents have spent any time in the NICU, there's certainly NICU specific support groups as well that can be a space to really form community. And then any sort of parenting community at all will be important so these families are less isolated. There's some practical function to this of, hey, this is expensive. We can buy and trade and baby products and things like that. But at the same time, also having that community is really important for these families who, again, can be a little bit more isolated when they're in the thick of things. Financial burden. So all kids are expensive. More kids are more expensive, certainly. And so often multiples are unexpected too. So there's going to be an unexpected financial burden on families, and that can put strain within the relationship of the parents and that relationship between the parents and the children. So, they might find that, okay, we're not just needing to buy one car seat, now we need to buy 2 car seats for our car, but we have 2 cars, so we need to buy 4 car seats, and those are our infant car seats, and now we need 4 more bigger car seats once we outgrow those. And, we were expecting 1 more kid, now there's 2 or 3 more kids. Our car's not going to fit this many kids. Our apartment, our house is not going to fit this many kids. Do we need to buy a new house and car now? and that wasn't necessarily a consideration before. Certainly, there's higher costs associated, especially with like prematurity during that first year in terms of medical costs, and then, again, paying for multiple children with childcare, and then certainly a multiplication of expensive, especially baby things like diapers and formulas. So at our visits, we definitely want to be screening for, like doing needs-based screening for ways that these families can be supported, whether that's getting them connected with WIC or different community resources, the health department for car seats and things like that, or other local resources for things like diapers to support them if there is a significant amount of financial burden for the family. And then again, I kind of touched on this a little bit explicitly and a little bit implicitly. So just to put it all on one slide, here's sort of a summary of some psychosocial impacts on families. So again, especially early on in like pregnancy, there's going to be increased risk. There's going to be a lot of anticipatory anxiety related to this is a very medicalized pregnancy. A lot can go wrong. My children are at increased risk for being born early. Certainly, there can be increased risk to mom, as mentioned, and that can cause a lot of challenges around the time of delivery as we're new to motherhood as well. Again, these moms generally can lack a lot of autonomy when it comes to what their pregnancy and what their delivery plan looks like, which can certainly impact them. And as mentioned, the data plays out that there are increased rates of postpartum depression. We touched a little bit on like grief and what that looks like for these families, which is not, unfortunately, not a terribly uncommon thing to occur for these families. And so we want to be able to create a space to acknowledge that directly with these families, which can be certainly a learned skill. Especially early on, these parents can feel very isolated, sleep deprived, and so supporting them through that will be important. And then, as touched on, lots of unique challenges for these families in terms of parenting well and financial burdens and things like that. So just some closing thoughts for the presentation. Again, overall, our multiples are a low percentage of our patients, but not an insignificant one, and certainly create sort of a disproportionate amount of morbidity and mortality. And so, again, good to know what the chorionicity of the pregnancy looked like, not only for like outcomes sort of perinatally, but like for thinking for the family from that holistic context. What did that pregnancy look for the family? How high stress was it? I mean, get some information from that, even without asking them directly. Certainly there are increased risks for delays, often related to prematurity. But again, we want to be comparing these children to developmental norms, not to each other, and making sure that they're referred early, especially our preterm infants, to like developmental clinic and other therapies that they might require. There's a plug for the sort of the medical home framework, especially for our medically complex multiples, but structured care coordination is going to be critical for these families. Again, strong interprofessional collaboration, making sure that these families are well supported, especially if they have a lot of different appointments, different subspecialties for multiple children, trying to coordinate these well, putting them together. Again, might create some extra chaos in the room itself, but can really ease the burden on these families. And then again, all of us will probably encounter families with multiples at some point, whether it's caring for one of a set or the entire set. And so it's good, I think, I hope that when you care for them in the future, you'll kind of just think back about this presentation and consider the larger context of what parenting looks like for these families and what they may have gone through in the past, and realize that certainly this can impact the family dynamics and how these families are parenting their children, and certainly will impact the environment they're growing up in, and that hopefully with consideration of that, it will really help us to provide more like holistic and individualized care for these families, because I feel like they do deserve a little bit of like individualized and unique attention. These are my references. That's us now. And I would love to hear if anybody had any like questions or additional thoughts or experiences that they wanted to share.
I have a quick question. Thanks for the presentation, it was great. When we talk about the growth of the twins, specifically male versus female, or just singletons, have you seen any differences in twins that have monochorionic pregnancies with twin-to-twin transfusion?
Yeah, I didn't find like specific data about that, but you're probably right. I imagine that like our monochoriotic pregnancies are like when there is greater growth discordance, that we're going to see probably some very unique differences in like growth related to that, and what catch-up growth is going to look like for those infants as well will certainly be very different. Yeah, so that's a good question. I don't know that I've seen the data for it, but it may be out there.
I don't know if there's studies about that, but theoretically, you wonder if it's just related to substrate being laid down in the fetal, the fetal time period.
Right.
And twins are tricky because you've got the donor twin, smaller, a lot of times a little more, if they're born premature, that one is actually more mature if there's not significant oligo and lung disease. So they're oftentimes a little more mature because they're more stressed. And it's the bigger twin who, with high drops and fluid overload, or they're the ones that are usually in more trouble.
Thank you.
I appreciate you bringing up kind of don't call them the twins or the triplets. I had younger brothers that were twins, and that was something that I think caused a lot of psychosocial issues for them growing up in our town. Everyone in the town called them, hey twin, hey twin, hey twin. And to the point that by the time they reached college age, they wouldn't even apply to the same colleges because they wanted to create their own identities. They did not want to risk even being in the same place anymore. And so, thinking about like how we as physicians, if we're caring for twins, can help to like reinforce that they are unique individuals and have their own identity. I think about one thing I like to do generally, and I'm sure a lot of us do with our epic, is putting in kind of your little Post-it to remind you of something about this individual. And I think if you do have twins or triplets, like probably even more important to try and put in some notes for yourself to remind you, like maybe they have a specific interest that the other one doesn't, and to just kind of help them when they're in visits with you to feel like, yes, they are their own individual and they're not just a twin or a triplet.
Yeah, I love that recommendation. I think it's a great idea. Yeah, thank you. Cool. Thank you, everybody.